everyone, Assalamu alaikum. This is Dr. Tazeen, your mentor and course director at Study FCPS, and I'm here with another session for the Triple P YouTube series, which actually is designed for all aspirants who are preparing for their FCPSOBG Feb 2025 exams to prepare you well for your exams, to make you practice by having the major concepts that you should grab the concepts and to make you successful in this exam. So today's session is about urogynecology. I'm here to make it easier for you that what are the major exam tested potential areas which can be asked in the exam, and you should have clear idea that how to go about in the exam. So let's start today's session and let's see that what actually we have to discuss with you. But before starting the session, keep one thing in mind, that your passion and your dedication, that is the key ingredient to pass any exam in the world. Okay, so this is something that keep your passion and dedication alive, and this will lead you to success. And all this hustle, all this hard work which you are doing these days, this will be an antidote to all your problems, and you will be successful with flying colors. So starting with urogynecology, whenever a woman or a patient, she is coming to you with any urogynecological problem or some urinary complaint is there, first of all, you should rule out the urinary tract infection, and you have to classify that what actually is the problem, and then only you can start the management options with the patient. But generally, if there are some concerns that you feel that there are some concerns in the daily lifestyle or with the general health of the woman, you can advise them lifestyle advice. But at the same time, you have to find out that whether this is urinary tract infection, this is urinary retention due to some problems, it is stress incontinence, this is overactive bladder, nocturia, or what actually is the problem that which you have to treat, and then you will manage accordingly. So the initial clinical assessment in all these patients is very, very important to, number one, to identify the predisposing factors. If there are any precipitating factors, that you have to identify, and you have to make sure that whether this patient needs referral to the specialist services or you can treat that. Okay, categorization of urinary incontinence or urinary problems is very, very important. And after the history examination, if you feel that this patient can get benefit from the general lifestyle or pelvic floor muscle training, then you can advise them. Generally, we are having stress urinary incontinence, overactive bladder or detrusor overactivity problems are there. Few patients, they can present to us with mixed incontinence as well. So the initial treatment would be based upon categorization of their problem. If they are having mixed problems, then you will treat that which is the predominant problem, and you can advise them the conservative measures which are basically dealing with both the problems. So a patient who is coming to you, you will do the initial assessment, which comprises of clinical history, physical examination, validated quality of life questionnaire, and incontinence severity questionnaire. Urine analysis will be performed, and frequency volume chart, which we call as bladder diary, that would be provided to the patient. If there is any presence of voiding dysfunction or pelvic prolapse is there, when two pathologies, they are coexisting, always remember in your exam questions as well that that is an indication of referral to the secondary care. When they are giving you a scenario in the exam that the patient is having prolapse as well as she is having urinary problems as well. Okay, so then there comes the conservative measures. Okay, in the conservative measures, what we have to do for this patient is that we will start the if it is mixed incontinence, we will review the fluids. If it needs that the patient is taking caffeinated fluids, fizzy drinks, or the fluids they need modification, we can advise them. Bladder training is advised. Pelvic floor muscle training can also be advised, and then antimuscarinic agents, they can be considered. If it is arch incontinence, then we can review their fluids and their caffeine intake. Bladder retraining can be advised for 6 weeks, and then antimuscarinic agents can be advised. And in case of stress incontinence, the first line management is pelvic floor muscle education, and pharmacological treatment can be considered. If the patient is unwilling for surgery, if the patient is unfit for surgery, then duloxetine can be advised. If the treatment is successful, you will complete the course and you will continue the treatment. If the treatment is unsuccessful, then you will refer to the secondary care to these patients. So what actually we are doing in the secondary care, there are two important points to know about your exam point of view. One is that the diagnosis of stress incontinence is a clinical diagnosis. Okay, so you will do the examination. If there is leakage of urine on cuffing, stress incontinence is demonstrated, then you can start the management of this patient. This is a clinical diagnosis. For the overactive bladder, after history and examination, to confirm your diagnosis, you have to go for urodynamics, which is basically the study of urine flow and bladder pressures. Okay, this is known as urodynamics. It comprises of uroflowmetry, cystometry, and more complex urodynamic investigations are also available, like video urodynamics, urethral pressure profilometry, and ambulatory urodynamics. Now, when we are doing the urodynamics, and this we are doing the uroflowmetry to see the flow rate of the urine, the normal curve is a bell-shaped curve, and the normal flow is 15 ml per second. Okay, so this is a bell-shaped curve, which is again exam tested area, that what is the shape of a normal uroflowmeter curve, which is bell-shaped. If there are any concerns that the flow rate is lowered, this curve is not bell-shaped curve, or there are some problems, then certain abnormalities can be there, which we have to find out. That if this is the situation, that this curve is normal bell-shaped curve, we have to see that what actually is the flow rate, how are the things. That is all which we can keep in mind. If that is not bell-shaped curve and the flow rate is reduced, then we have to find out that what can be the problem which is causing this. This can be obstruction because of cystocele resulting in urethrocoele, or this can be hypocontractile bladder as well. Then if there are upstrokes are there, then there is there is no uprise of the curve, and then again there are upstrokes are there. This is again an abnormal graph which is actually showing obstruction or hypocontractile bladder, which should be kept in mind. Okay, so the abnormal flow can be due to voiding difficulty, that can increases the risk of retention after any continence surgery, or this can be due to obstruction, or this can be due to cystocele. All these things, all these differentials should be kept in mind. The second part of urodynamics is cystometry. Cystometry is basically the study of bladder pressures. Okay, it evaluates the filling and voiding phase of micturition, and it evaluates that what actually is the relationship between pressure and volume. Okay, so we are measuring on the cystometry when is the first desire to void, when is the strong desire to void, and what are the maximum cystometric capacity of the bladder. Increased bladder sensations can be found, which indicates detrusor overactivity. Decreased bladder sensations can be found on the cystometry, which indicates that hypocontractile bladder can be there. So all these things, they should be kept in mind while we are doing the cystometry. And the other most important thing is that we should know the normal values so that we can differentiate among the different values. I am not going into the details of the urodynamic graphs. The reason is that image questions are not coming up in the exam. So I would focus more on the theoretical aspect. And when we will prepare for the FCPS extended talks, then we will interpret the graphs and we will apply them there, that how this is tested in the exam. So from here, you should know that what actually are the components of urodynamics, what is uroflowmetry, what is the shape of normal curve, what is the normal flow rate, okay, what is cystometry, which pressures we are measuring, and if there is any problem with the pressure, with the, if increased bladder sensations are there or decreased bladder sensations are there, then we can do the, we can assess that what is the problem. So in the cystometry, basically we are measuring three pressures, okay, vesical pressure and abdominal pressure is measured. Okay, so how we are measuring the intravesical pressure? A catheter is inserted into the bladder, which measures the intravesical pressure. For the abdominal pressure, a catheter is inserted into the rectum, which measures the intra-abdominal pressure. And to calculate the detrusor pressure, abdominal pressure is subtracted from the vesical pressure and we get the detrusor pressure. And this is exam tested area that they can ask you that how the detrusor pressure is calculated. The correct equation you should be knowing, that how to go about for calculation of detrusor pressure, which is very, very important. This is normal bell-shaped curve of uroflowmetry, which you should know that the maximum flow rate is 15 ml per second. This is the time which is taken for the flow time, and time to reach maximum flow rate is here, which you can find. Okay, and the area under this curve is the total voided volume. Okay, that is total voided volume, which is under the area which is under the curve. When we are doing the uroflowmetry, there can be several patterns. As I told you that several peaks can be there, which can be caused by bladder outflow obstruction. Flow rate can be reduced. Okay, this also can be due to urethral stricture. Okay, and then very high flow rate can also be there, a rapid upstroke and then downstroke, which can be due to possible detrusor overactivity or high speed squirting to overcome an obstruction. So this can be the pattern on the uroflowmetry when you are doing the uroflowmetry. The normal values of bladder function are very, very important to know, so that when you are given a statement, you can interpret it that whether this is normal value, whether this is abnormal value, and how to go about. Okay, residual volume is less than 50. First desire to void is between 150 to 250. Strong desire to void does not occur until after 250. Cystometry capacity of the bladder is 400 to 600. Flow rate is 15 ml per second with a detrusor pressure of less than 50 centimeter of water. Bladder compliance between 20 and 100 ml per centimeter of water, which is measured 60 seconds after reaching the cystometric capacity. And no uninhibited detrusor contractions are there during the filling phase despite provocation. Okay, so what does that mean? That simply means that during the filling phase, the detrusor should stay calm. There should be no uninhibited detrusor contractions. So detrusor should be at peace during the filling phase. No stress or urge incontinence is demonstrated despite provocation, and void occurs as a result of voluntarily initiated and sustained detrusor contractions. After reaching the capacity, then voiding can start. Then there comes an exam question that a lady complains of frequency, urgency, nocturia, stress incontinence. So what is actually the first step? So before jumping to the options, first of all, from the statement, you have to find out that what is my diagnosis, what actually they are talking about. So when I have a look at this, she is having frequency, urgency problems, which is of the overactive bladder. Then they are stress. This is stress incontinence. It means that there is leakage of urine on coughing and sneezing. So mixed incontinence is there. One important thing to remember is that when urodynamic findings are given, we say that this is detrusor overactivity. And when urodynamic finding of stress incontinence is given, we say urodynamic stress incontinence. When just clinical description is given, we say overactive bladder. Okay, we have to confirm the diagnosis that this is detrusor overactivity, but this is overactive bladder. Okay, so the first step for stress incontinence is pelvic floor muscle training. The first step for the overactive bladder or detrusor overactivity is bladder training. But here, as this is mixed incontinence, so we shall be advising pelvic floor muscle training and bladder training, and this is the right answer, and this is how you have to interpret. They have asked us the first step, which means that we have to start with the conservative measures. They have not asked us that what would be the first medical management for this. That can be oxybutynine, tolterodine, derifenacin, or if they are not tolerated or not effective, then we can go to myrabegron. But here actually the question leading statement says that what is the first step? So our answer would be conservative measures for the mixed incontinence, which can be both. Moving forward to the next question, a patient has presented to you with urinary complaints. First desire to void is at 100 ml, bladder volume is 300 ml, detrusor pressure is 30, and it leaks on stress. Flow rate is 20 per second, and residual volume is 50. So what is your diagnosis? So here, if we see that first desire to void is at 100, we say that it should be at 150. Bladder volume is 300 ml. We say that the bladder capacity should be 400 to 600. Detrusor pressure is 30. Detrusor pressure during the filling phase. As I told you, that detrusor should stay calm during the filling phase. Its pressure should be less than 15 centimeter of water. So here, basically, the detrusor is 30 and it leaks on stress as well. So apart from having the problems of detrusor overactivity, there is stress incontinence is also demonstrated. So this is again a mixed urinary incontinence. Increased detrusor pressure is there, stress incontinence is there. So this is the answer for this question, and this is how you have to interpret the questions in the exam. Another question says that a patient has presented to you with urinary complaint. First desire to void is at 150 ml, which is normal. Bladder volume is 400 ml, which is again normal. Detrusor pressure is 10. Again, that is within the normal range as it should be less than 15, but continuous leakage of urine is there. So apart from having the normal volumes, this patient is having continuous leakage of urine. So this is not associated with overactive bladder or detrusor overactivity. This is not the leakage on coughing and sneezing. So not a stress incontinence. This is continuous leakage of urine, and continuous leakage of urine is always in the fistulas. Okay, so all the findings are normal, but there is continuous leakage. So this is urinary fistula, which needs to be ruled out that which fistula it is. So this is not mixed incontinence. This is not detrusor overactivity. This is not stress incontinence. This is fistula, which is the statement leading us towards fistula. So when we talk about stress incontinence, that is the commonest urinary complaint for which the women seek advice. So the most common urinary complaint, exam tested area, that is stress incontinence. 1 in 10 women will suffer from it at some point in their lives. 50% of the incontinent women complain of pure stress incontinence, and 30 to 40% of incontinent women have mixed symptoms of urge and stress incontinence. Then there comes that stress incontinence. What can be the pathophysiology and etiology? It occurs when the intravesical pressure exceeds the closing pressure on the urethra. Childbirth is the most common causative factor leading to denervation of the pelvic floor, and usually during delivery. Estrogen deficiency in the postmenopausal woman, that can also leads to weakening of the pelvic support and thinning of the urothelium, and occasionally there is weakness of the bladder neck. It can occur congenitally or through some trauma, radical pelvic surgery, or irradiation. So the reason can be childbirth, it can be due to postmenopausal problems, estrogen deficiency, or it can be due to some congenital problems or trauma from the radical pelvic surgery or irradiation that can lead to stress incontinence. So whenever a patient is coming to you with the stress incontinence, after the first thing which you will advise to the patient after clinical assessment and reaching the diagnosis that stress incontinence is there, that would be pelvic floor muscle training. These are supervised pelvic floor muscle trainings, 8 contractions 3 times a day for 3 months. And also, if the height to weight ratio is higher, you have to advise reducing weight. Okay, so lifestyle, general lifestyle measures are always there. If the patient is a smoker, you have to advise to stop smoking. Weight is higher, you have to advise weight reduction. And also pelvic floor muscle training is the first line, and it is the exam tested area as well as potential exam question, that what is the first line for stress incontinence, that is pelvic floor muscle training, supervised pelvic floor muscle training, 8 contractions 3 times a day for 3 months. Then if that is not helping the patient, the next step can be surgical procedures, and Birch Colpus suspension is preferred. Okay, if the now the statement of the question says that the patient is having stress incontinence, pelvic floor muscle training is not helping the patient, she is unfit for surgery, she is unwilling for surgery. So what can be the option for this patient? That can be duloxetine, where it comes that it is, if the patient is unfit for surgery, if the patient is unwilling for surgery, then we have to give duloxetine to the patient. Then another statement of the question says that a patient is diagnosed with stress incontinence, pelvic floor muscle training is not helping the patient, she is not willing for surgery, and she cannot take duloxetine due to side effects. Okay, side effects of duloxetine are there, so she is not able to take duloxetine. So what would be the next option for the patient? We can give intramural bulking agents. Now if the patient still is not a suitable candidate for the intra bulking agents due to patient's preferences or anything else, then the last resort is artificial sphincter, which we can go for. So this is actually the stepwise approach for the management of stress incontinence, which we have to keep in mind. Then there comes the overactive bladder or detrusor overactivity. Okay, so the first line management for this would be midstream urine to rule out any urinary tract infection, as these patients are coming to us with frequency, urgency. So urinary tract infection can also be there. After urine analysis and after midstream urine, the patient would be advised to maintain bladder diary, which are actually the frequency volume charts. We have to see, they are provided to the patient for 3 days, and we have to see what actually is the fluid intake and what is the urine output of the patient, so that we can correlate it that they are having the overactive bladder with increased frequency or urgency. Fluid modifications can be advised to the patient. Lifestyle modification can be advised to the patient. Again, the general lifestyle measures would be advised to the patient. If all these are not helping the patient, the first line medical management for this patient would be oxybutynine, tolterodine, and derifenacin. Now remember one thing for oxybutynine, that it is not given in the older age group. Okay, if oxybutynine, tolterodine, and derifenacin is not given to the, is not helping the patient, then there comes another medicine which is myrbetriq, that we will advise myrbetriq. Now if all these medical managements have failed and they are not helping the patient, the next step would be multidisciplinary team and urodynamics. Okay, so you will send the patient for the multidisciplinary team review, and urodynamics would be carried out in this patient. And after urodynamics, we can advise the patient botulinum toxin injections. Botulinum toxin, you can always remember, as this is a toxin, it paralyzes the bladder. So the patient needs clean intermittent self-catheterization. They should be taught about catheterization, or they need intermittent catheterization to empty the bladder. If somehow botulinum toxin is also not helping the patient, then the next step would be neuromodulation, sacral nerve neuromodulation or tibial nerve neuromodulation. If neuromodulation is also not helping the patient, then the next step would be augmentation cystoplasty, that you have to increase the capacity of the bladder. You have to augment the bladder, that is known as augmentation cystoplasty. If augmentation cystoplasty is also not helping the patient, then the next option would be that now you have to change the route of the urine, so urinary diversion can be done in these patients if all other measures they are not helping the patient. Okay, so this is basically about the management of the overactive bladder, starting from the midstream urine, lifestyle advice, moving towards bladder diary, then moving towards the medical management. After medical management, urodynamics, botulinum toxin, neuromodulation, augmentation cystoplasty, and finally urinary diversion. We are so thankful to all the FCPS batches for your trust in us, and we are grateful for having you, and we wish you all the very best for your exams. So this was about a quick revision session of urogynecology. I hope this will help you in your exam, and I wish you all the very best for your exams. Have a great day.